Okay, so let's start with infective disorders. So I went ahead and your book really quickly talked about acute bronchitis, but I wanted to review it a little bit because we talked a little bit later about chronic bronchitis, and it's a little bit different. So acute bronchitis, it's that bronchial tree. So remember your lungs, you kind of have your main bronchus, and it splits apart and goes into your different right and left lobes. And so that's when your bronchial tree gets irritated and inflamed. When the mucous membranes start to become inflamed, they start producing extra mucus. And so if you have acute bronchitis, which can be like infection, you start coughing up a lot of mucus usually because the airways are so irritated, they're producing extra mucus. They're trying to get rid of that irritation. So it's usually isolated episode. And it's usually caused by a virus, right? Maybe you have a cold, you have something that then comes and infects those bronchioles, and it's kind of a one-off. And you might have it occasionally, but it's not chronic. Yeah, question? You should be able to cough it out. Yes, yeah. We want them to cough it up. You guys remember from last week, what is the expectorant? That's kind of our example medication. Mucinex, yeah, or guaifenesin, right? That's our expectorant that we give to patients. So keep your medication sheets handy. There were several people, like as you did your medication homework, I noticed that you maybe didn't look up the medication I would have looked at for respiratory. So we're going to be going over that, making sure we're looking at them. With guaifenesin, what are some nursing indications? What are things we want to make sure to teach our patients when they're taking it? Right, a lot of fluid, like one of the big ones, because we know that if they're dried up already, those secretions are going to be harder to get rid of. All right, so bronchiectasis. This one, I think I like how it shows like the tree and how it comes down. So this is a chronic inflammation, chronic infection, and you have dilation of either one or more of your large bronchial. See how like here it's nice and thin, it kind of tapers down. On this side, you got this dilated area, kind of a sac that's there. It usually is a secondary condition. All right, so it's not that somebody has bronchiectasis and that's just their whole issue. It's that you would develop bronchiectasis from another condition. So usually tuberculosis, cystic fibrosis, maybe asthma. When you have those sacs, actually, I'll get to that in a second. So signs and symptoms, right? If you have irritation, infection in your airways, you're probably always going to have trouble breathing, a cough. These guys have a lot of sputum, and we see anorexia. You know how we see that? It's usually this is a cough and just fatigue. A lot of times they just don't feel hungry. It's real difficult to eat. They often have recurrent infection, especially if you think about those dilated airways. You know, virus, bacteria, whatever it is, it can get kind of trapped in here. It's more difficult to get popped out. And so it can cause these like kind of chronic infections in here. We oftentimes can see clubbing of the fingers. I've got a picture I pulled up. Anybody ever seen somebody clubbing before? Mm-hmm. Yeah, it's always interesting to me. And then we usually hear hospitals in emergency with these patients. Here's clubbing. Now this isn't somebody who's, this is older person, they've had respiratory illness for years, but you get kind of a rounded, large nail beds. This is called finger clubbing. So if you ever see a patient with that, if you're out in your clinical, go look. There's going to be some sort of respiratory issue that they have, some sort of long chronic illness that this is a sign of. Can you explain a bit why it makes them bigger? I'm so actually I don't know. I started to do a deep dive on that this week. And I was reading through all these journals, and it was just all talking about how it's a sign of that. It's something to do with the blood flow. Mm-hmm. There is something with the impaired blood flow. So we think extremities, right? If we're not getting oxygen, if we're not oxygenating as well as we want to because of respiratory disease, the places that are most affected are going to be the farthest from the heart and lungs. And so with the fingers, I don't know why it forms that, but it's so interesting. Okay, I'll do another deep dive into this. I'm not for you guys. It's really interesting. All right, so What kind of testing do we maybe anticipate with somebody with bronchiectasis? Think you guys. Looking at their white blood cell count, which is in the CBC, sputum cultures. What time of day do we like to get our sputum cultures? Morning, first thing in the morning. Yeah, good job. We might get an X-ray, or the arterial blood gas. They all give us good information. Nice job, you guys. Our interventions, we want to do whatever it is that's causing the issue. We want to try to keep those airway clear. So if it's from infection, we're going to be giving them antibiotics. If it's a bacterial infection, we might give them those eucalyptus or expectorants to pop out the secretions, bronchodilators. So on your sheet, you guys have, I believe, a section on your medication sheet that has adrenergic bronchodilators. Is that right? What does it say? Oh. So for that, our action is going to be bronchodilation. The medication example we like to use is albuterol. So albuterol. Anybody know some nursing interventions or nursing something we need to know about albuterol? Not rinse them out, but it can make them feel anxious. What is an actual an objective symptom that we see with patients when we give them albuterol? Tachycardia, makes your heart rate go up. Anybody here asthmatic or using albuterol inhalers? I didn't tell you guys one time I was driving home and I have asthma. I was driving home from my clinical and it was last fall and I just wasn't feeling good. So I need my inhaler. Took my inhaler, drove home, and then thought I was having a panic attack on my drive home. And it took me a minute to realize, oh no, this is just my heart going up a lot because I just took my albuterol. Oh. Oh man, how did I classify these? This is for the adrenergic blockers. Yeah, the anticholinergic. And actually, we can talk about that too. But let's finish talking about the albuterol. So we know with the albuterol, it causes your heart rate to go up. So if somebody who already has tachycardia and their heart rate's high, are we going to want to give this medication? Okay, we might not, because we know it causes their heart rate to go up further. And especially this new medication, we want to do some teaching and tell patients your heart rate's going to go up. You might feel a little bit anxious or jittery. That's a normal finding. All right, so then let's talk about the anticholinergic agents. So these also help with bronchodilation, but they don't have the same effect of raising that heart rate. So somebody who maybe has tachycardia, you don't necessarily want to give them albuterol. We might give them Atrovent as well. That's the anticholinergic. It's an example medication, Atrovent or Spiriva. That's another inhaler that they might use. And then it's a bronchodilator as well. Yes, it is. And this is one of those medications because it's the anticholinergic. We want to be careful with patients with glaucoma or BPH, which is benign prostate hypertension. So the big takeaways, albuterol, bronchodilator, opens up those lungs, and that can be given in a rescue inhaler or a nebulizer treatment. Have you guys done nebulizers in the lab? We've seen them. Seen them? Okay, yeah. And so those are usually a little bit, if somebody's more acute, they're gonna be giving it a nebulizer treatment because it aerosolizes it, it's a more continuous, it's usually a higher dose. So if somebody's more ill, more distressed, they're gonna get nebulizer, not just the inhaler. Okay. Bum, bum, bum. Pneumonia, happening at changing things. So a lot of the chronic pneumonia are people with pneumonia. That's just a general classification of lung infection. So you get inflammation at the alveoli and they fill with exudate or gross fluids, right? So with pneumonia as well, you can also be coughing up some pretty nasty secretions. Because you have all that exudate, the surface area of those alveoli are kind of blocked up, so they can't exchange oxygen like they normally would. So that's why we see difficulty breathing, maybe lower oxygen levels, acidity in water, and things like that. Usually it's bacterial. That's the #1 cause of pneumonia, but it could be a virus. I've seen fungal pneumonia occasionally. Aspiration pneumonia, right? We think about our patients who have delayed swallow or impaired swallow, right? If they aspirate food or fluids, that actually can cause pneumonia as well. And then we talked about artificial ventilation. So ventilator associated pneumonia. Any patient that has a chronic ventilation, and you guys might go to Park Roads eventually, which is a long-term care facility that has patients who are chronically ventilated. Those patients are more at risk of having pneumonia because they've got all these tubes and mechanisms. Like normally when you and I breathe, right? If we're breathing through our nose, there's all kinds of filters in there. In our mouth, usually most things get filtered out. But these patients are chronically ventilated, they don't have that same protective mechanisms. And so they're more likely to get pneumonia. You also have chemical pneumonia. They're exposed to chemicals you inhale. That can damage the lungs and cause pneumonia. All right, who's at risk? Just like most everything else, if you're really young, you're really old, or your immune system isn't working, right? That's pretty much for everything. Those are the people who are most at risk. So how do we prevent pneumonia? You guys can work together or individual.
Well, I want to know about hash hands.
I like to wash hands. Ambulating, coughing, I think it's an spirometer. Okay, there's one thing that's missing on here. About prevention and community health. Vaccinations, right? Right, you can get, especially our patients who are at risk. Our elderly is usually who you guys are gonna see. People who are in long-term care facilities will get the flu vaccine and the pneumonia vaccine as well. So you want to help prevent them from getting pneumonia. We also, it's kind of funny, we talk about the flu vaccine. Well, how does that prevent pneumonia? You can get the flu and develop pneumonia, right? You can get a upper respiratory infection and then develop pneumonia from that. Last fall, when I was talking about my inhaler panic attack, not really panic attack, over the break after that, I developed COVID. And then after that, I got pneumonia. And my lungs, I would be in the middle of class lecture and I had to get out my rescue inhaler to try to breathe better. So just my lungs were not working so well. My pneumonia was caused from the COVID that I initially got. Ended up having some lung damage with that pneumonia. So know that if we can prevent them from getting a flu infection, that might help prevent them from getting pneumonia as well. Frequent mouth care. I don't like this continuous, don't even look at the section for that. But the mouth care, that's really important for our ventilated patients. Also for our patients who have dysphagia or have be swallowing. When do we provide mouth care for our patients who are aspiration risks? after eating? Before eating. Because, right, if we know they're at risk of aspirating, we want to wipe out any extra bacteria from their mouth, because in case they do aspirate, it's less likely to have that bacteria from their mouth that would be aspirated. And it seems like opposite of what we normally would do, but those patients that are at risk for aspiration, we're trying to decrease the bacteria in their mouth because we don't want it to go to their lungs. Signs and symptoms: chest pain, fever, cough. It's yellow sputum. Sometimes they say rusty, and that's from just a little bit of old blood. It's not a lot of blood. It's not, we wouldn't call it hemoptysis where you're coughing up blood, but it's that airways are a little irritated that have just a little bit of blood in it sometimes. Crackles and wheezes are often hurting the lungs. And then what is malaise? Tired. Yeah, they're just tired. They don't have energy. Complications, well, they might get pleuritis. And what pleuritis is? It's inflammation of the pleura. That's good word building.
Yeah.
What that means is we have our pleural cavity, and that the pleura surround our lungs. And I remember our diaphragm, as we inhale and exhale, that's our diaphragm contracting and relaxing. As our lungs inhale and exhale, they slide against the pleura. It's a nice smooth slide. If we have pleuritis, there's irritation and it doesn't slide as easily. And sometimes you can even hear a pleural rub. Do we have it up here? It's like we do, it's like really excruciating. Very, very painful. Yes. I think a little bit later I have a video where you can hear what the rub sounds like. And it's very painful because normally, like right now, you guys have a nice, hopefully not inflamed pleural space or pleura. And you're sliding, the lungs are sliding around inside it without any issue. When it's inflamed, it's like catching, and it's very painful. You might have pleural effusion. I have a picture of that a little bit as well. So I'll talk more about that in a minute. Atelectasis, right? Collapse of the alveoli. And it might spread the infection, right? That's another complication. You have pneumonia and you go out to the grocery store, you might be spreading that around. That's a complication. So if we're caring for patients admitted with pneumonia, which of the following would concern you the most? Oxygen set of 94 on 2 liters per nasal cannula, bilateral crackles, new onset of confusion, or coughing up periodontal sputum.
Hold on one second. I don't think I shared my screen. That's gonna make it hard to watch. Okay. And the answer is new onset confusion.
So good job, I think, virulent sputum, that's always a good key word. But we expect there to be some kind of yellowish infection that patients are coughing at. We don't expect confusion, right? New onset confusion, I think they're not, right? So pneumonia, we give them antibiotics. If they're doing okay, stable versus unstable, right? Stable, you can have oral antibiotics. Stable, IV antibiotics, usually have to stay in the hospital. If it's caused from a virus, maybe antivirals. We want to give them bronchodilators, expectorants, oxygen. We might even get fluids too. Which percent of people infected with Mycobacterium tuberculosis develop TB? So we're moving on to talk about TB. What is our percentage of people who, if they are infected or get it, like it comes into your system, actually develop tuberculosis?
Look at these wide responses. So interesting. All right. And it is
About 10 to 15% of people who are infected with TB contract it. So, or 5 to 10, not 10 to 15, 5 to 10%. So you can be exposed to tuberculosis. It can go into your lungs even, but it's a very small percentage of people that actually have an active infection. infection that develops. Your immune system is usually what finds it, destroys it, and then keeps trucking. If you have low immunity, it might activate. So that's why when you guys using as a PPD, anybody had a PPD test, a tuberculosis skin test? Sometimes people can test positive without having an active infection. Okay, so that's why, I mean, I don't know if I'd like to do this weird thing, like there's lots of TV fast or something. Is this distracting? Should I turn the light off over here? Yeah, that's really odd. All right, let me know if we need more light or not, we can chat with them. So with TB, who's at risk? Well, I know we talked about old, young, and immunocompromised, but we also have new immigrants, sometimes not known in different people from different countries. Might not have the same vaccinations, the same healthcare, there are more risks of having TB. And then those with HIV, which that kind of falls into the immunocompromised bucket. Signs and symptoms, so cough, yes, but the blood tinge sputum, night sweat, anorexia, and weight loss, those are the three hallmark signs and symptoms of tuberculosis. You ever watch like old movies, you know, somebody whose grandpa's in the corner and he's coughing up blood, like it's like, wait, we got two probably have to, probably, but it's true, that is one of the big hallmarks of tuberculosis. You can see low grade fever, you might have some chest pain or dyspnea later, but hemoptysis or blood tinge sputum, the weight loss, and then the night sweats, those are like classic tuberculosis. So we talk about the PPD test. Sometimes they'll do a chest x-ray, right? If PPD comes positive, they want to do a chest x-ray to make sure there's not an active infection happening. They might do sputum culture. Really, the gold standard is the quantiferin and the TB spot test. A lot of times with like a school, that's a man having to do that. So the PPD, it's up to you. With tuberculosis, there's a long treatment cycle for this. So if you have it, it's often 6 to 24 months to fully get rid of tuberculosis, which is why we are so diligent about testing our healthcare workers, about if you're in long-term care facilities, those patients, the residents there, we usually always give a TB skin test when they're admitted, and usually once a year. We want to make sure that they don't have that right? So it's very important to treat. Talks about occasional surgical removal, very rare. The big thing I want you guys to know, especially if you start working in public health, we track these patients that have tuberculosis. And if you're a public health nurse, one of your jobs might be going door to door and watching the person take their medication for TB. Because we have to ensure that they're compliant with the medication, right? Because it takes such a long time. Most patients are fairly compliant with medicine, but if we're telling them they have to take it 6 to 12 months, it's a long time. And we know the repercussions are they will be spreading it out to the community if they don't take it. There's a lot of, like, I love how medicine uses technology. So now, a lot of times, instead of going door to door, they set people up with videos where you can virtually observe somebody taking their medication. Sometimes they have patients come into clinics routinely to take their medication. But there's very strict follow-up with patients who have TB. So anyway, it's just so interesting. I also went on a deep dive about Washington State and how we treat patients with tuberculosis and how we monitor, and there's a lot of really interesting information on the CDC in Washington State. Yeah. So, yeah, especially if you can't find discharge. Yeah, before COVID, we were always, TB was like our big respiratory thing that we would check for. In fact, yeah, it's a little bit. Yeah, I didn't really talk about it so much, but isolation, right? This is one of those times if you're in an acute care facility with tuberculosis, they usually put you in a negative air filling room. Which has anybody seen one of those before? So most at least most acute care, most hospitals, sometimes long-term care clinics, but not usually. They have specific rooms, usually 1 or 2 for the department, and it's negative air flow, which means their air ducts, their air vents aren't connected to the rest of the building. They are specifically, they're cooling air and then venting directly out into your, you know, or whatever, so that the patients who are breathing in and out and maybe breathing out tuberculosis particles, it doesn't go into the air vents and spread out to the rest of the hospital. With those rooms, it's funny because if you don't close the door all the way, the door will always pop back open because it's negative pressure. So you have to make sure you close the door all the way. And as care providers, you usually have to wear a 95 mask or one of the half things, to help with the airflow. And then all that. Before COVID, that was one of the few times we had to do that whole thing. And then once COVID happened, all of us old nurses like, really for everybody? Like, that's a lot. So, but it is a big, it's a big deal for not. Okay, so question, when you're reading a PPD test, the nurse should check for which finding. I mean, where you work, you guys might be reading this for patients who come in to have the test.
Are we looking for redness, edema, itching, or induration? And it's induration. What does induration mean?
It's raised, right? When we put it in, we want to see that little like wheel that forms. And then how many days or how many hours do they need to wait before it's red? It's usually 48 to 36 hours. They kind of give you a window, but at least 48 hours. And at that 48-hour mark, the wheel has disappeared. It's been absorbed. And if they have a raised area there, and it can be reddened, it might be, but that's not, if you just have reddened skin area, but no induration, no raised area, that's still a negative test. All right, so now we're in the groups. We'll take a break after this. What I want you guys to do is to think about prevention. Oh, what? Oh, I put this slide in a weird spot. Okay, we talked about all this. Oh, actually, good question. If you have to take a TB patient, let's say they're in the hospital, they're in the nice surgical room, if they need a chest X-ray, they want AP and lateral, what do we do? We put a mask on the patient. Do we put a regular surgical mask or a 95? It depends on your facility policy. Sometimes they'll just say put a surgical mask on, but we want to do what we can to reduce that spread of the TB. Because if you can do a portable chest X-ray, then we just want AFP, which is anterior posterior. Usually you can do a portable X-ray machine. But the laterals, oftentimes they have to go down to the X-ray department, or if you do a CT scan or something that's not portable, right? We have to be able to get that patient to a treatment, whereas the need to be putting a mask on them. Okay, now is a good part. So what I want you guys to do as a group is to think about nursing interventions for these nursing diagnoses. I'm going to assign each group a nursing diagnosis. Before we move on to these, who's been with career clinicals already? Okay, so I'll tell you guys before we go. And then so our concept maps, when we're doing those, we have issues. We think about nursing interventions. Like, what do we do about these problems? Usually students fall into two categories. They're either an assessment or an action person. And so what I mean by that is if somebody has respiratory issues, oftentimes they're like, oh, I would assess this, I assess this, I assess this, I assess this. They're all about the assessment. And there's some people who are action people. They're like, ooh, I think they probably need this, and I want to do this, I encourage them to do this. Like, so there's two different parts to the nursing interventions. So as a group, I want you guys to come up with at least 5 or 6 nursing interventions for your nursing diagnosis. So you've got, again, right here, impaired gas exchange, ineffective airway clearance. You guys are ineffective breathing pattern.
Resuming and stopping recording. So for the impaired gas exchange,
They talk, I kind of like how it's got monitor and what we're doing. Right, no, we want to monitor lung sounds, with like have refill, but then also positioning. Good laying down, that's one thing that we talk about. So like if you have a right-sided pneumonia, we talk about positioning, try to get you to expand your lung fully and also to expel or get stuff out. So if you have right-sided pneumonia, we're gonna probably encourage you to lay down on your left side. They try to get you to get all that stuff up out of your lung and help increase expansion. Ineffective airway clearance, right? So a lot of this, we think about the airway, but we don't have to maintain it, especially if it's clogged up. We're not gonna get those staphylicosis and stuff like that. The flutter valve, right? That would be a great one we talked about. Ambulating. Ineffective breathing pattern. So with this too, it's often treating the cause, like diaphragm breathing as well as they should. That's one thing that's a really good thing to think about. If it's some of these issues, what's the cause of it? Decreased activity tolerance. I think you guys got all of these. One thing, obtain a bedside mode, right? That's one of breaking up things, but even walking to the bathroom might be too much for our patients if they're having an exacerbation of a respiratory condition. One thing to remember is, especially for tuberculosis, is ineffective health management. It might be any of these long-term conditions as well, because people get tired of managing all these things. And so they might not want to take their medication, or they might not want to do the thing that they want to do, or they should do to take care of themselves. So ineffective health management is another nursing diagnosis. So as you kind of you're continuing to go to clinicals, or if you start going, think about that as being one of the issues about like kind of under an education heading, you know? Do they know what they should do? Maybe are they following through with it? Okay, before we go to restrictive, let's take a break. How about we come back at 10 after? Sounds great, yeah, okay. How are we with Candy? Was Mark Candy expanding or put that? At least we're not talking about like high cholesterol this week. Sure. Right, that's true.
have you had your all right, so
I'm gonna try to get through most of this today, just because I don't have to come back to go to respiratory. Let me know if I'm going to have to go down. We're gonna talk about those restrictive disorders, right? So that's where we don't have the expansion and contraction like you normally would. So pleuritis or pleurisy, actually we already talked about that. So it's always caused by another issue, right? And it's that sharp pain, shallow breathing, and there's also a friction rub. I'm not put it in the video. Oh, I have a video that had the sound of a pleural rub. It kind of is like a sound. Like, so think about if your lung is expanding and it's catching, it's like. I'll post, I have some links to like good sounds. Like, I think ATI helped them as well, but a pleural friction rub is kind of like this, like you can almost hear something catching. They usually are gonna do a chest X-ray, and usually it's testing to determine like what causes, like what's happening. So pleural effusion, that's where you have extra fluid that builds up between the lungs and that pleural space, and it kind of pushes your lungs so you can't fully expand them. So I think, oh yeah, I took this is not from your book, but I thought it kind of helped explain. When your pleural space, the pleura is intact, but it's all filled up with this extra fluid. And so now your lung isn't able to expand how it should. And just like this picture shows, it might only affect one side if it's depending on the cause. So when we look for the cause, it's usually transudative or exudative. What that means is transudative, it's like edema, it's swollen, there's like fluid in general, just like if you have heart failure or liver failure, you have extra fluid that's backing up, that might be what the pleural fluid is from. Exudative, that's where it's infective material, so that's where you might have like just a bunch of, pus or infection filling up that pleural space there from pneumonia, tuberculosis, might even be some cancer issues. Which is basically fluid. Yeah, exactly. So signs and symptoms of pleural effusion, dyspnea, right? They can't get a good breath because their lung isn't expanding how it should. They might have cough, and again, you might have diminished lung sounds, because if you think back through this patient, if you listen to their lower lobes, you're not going to hear anything because your lung isn't expanding. Pulmonary fibrosis. So moving to a different topic, this is another restrictive. This is where you get injury to the alveoli and scarring. So normally the alveoli, they're kind of, those are those little sacs at the end of all of your lungs. Those sacs that expand, you contract, and that lung, and that's where actually we pick up oxygen and send it out to our bloodstream. Because of the scarring, they don't expand and contract like they're normally would. They can't fill like they should, and so they're not able to exchange oxygen. So it could be hereditary. There could be some virus or damage. It could be like think about chemical inflammation that can damage their lungs and cause fibrosis. It could be the immune system. The immune system attack your lungs. So with this, usually your dyspnea, you might have some crackles, fatigue, that clubbing. Remember we saw the picture of the clubbed fingers? Because the fibrosis is usually a chronic thing. Even though something, it can be caused by different things of a chronic condition, like that swelling is something, it doesn't usually improve or get better. So we're going to do tests on them, just like you guys talked about the x-rays, CT scans. They might do a bronchoscopy, and that's where they have a thin flexible tube that goes down your mouth into your airway, and it looks at your airways to see if they can kind of see what's happening in there. You would be sedated for that patients are sedated, right? Because you really uncomfortable to go on your lungs. Interventions, well, it's going to be some medication, depending on what it is. Smoking cessation, right? Anybody who's smoking who has a respiratory condition, actually, regardless, if you smoke, we're going to encourage them not to, especially if they have a respiratory condition. It's just an exacerbated course. We're also going to really encourage these people to get their vaccinations because we know they're more at risk because they already have lung issues. Sometimes these people, if it's extreme enough, might even need a lung transplant because their lungs just don't function. And whatever we do is going to help, but it's not going to actually improve their lung function. We're just trying to maintain. Atelectasis. So that's where our alveoli collapse. There's a big patient population that we see that has atelectasis. Post-op, yeah, our post-operative patients. They're sleepy, they're sedated. Sometimes they have belly surgery, they don't want to take deep breaths. And so those alveoli, they're not being expanded and they just collapse. So it's hypoventilation, that's what causes it. And the signs and symptoms, fine crackles, diminished breath sounds, and sometimes in the chamber, usually we'll also see a low-grade fever. A low-grade fever on somebody who is post-operative, we often think, oh, probably atelectasis, and you just start eating with deep breaths. Right, so cough and deep breathing. into the spirometry. I was with the full-time group last week with the clinical side, the guy had surgery not too long ago. And his incentive spirometer was up across the road. And I was like, oh, how often you use them? He's like, well, often enough. And I was like, well, that's what you do. So you actually can use this regularly, right? Doesn't do him any good across the road. Obstructive disorder. So with obstructive, this is where something's actually kind of blocking up the lungs, or not able to get rid of something's actually in the way. So COPD stands for chronic obstructive pulmonary disease. It's actually a combination of issues. I like how this Venn diagram kind of shows how you can have asthma and you could have emphysema, or you might have chronic bronchitis. But eventually, a lot of these patients over time, they'll end up with things overlapping where you have COPD. So if you have somebody that has the diagnosis of COPD, usually their background is maybe they had chronic bronchitis that's developed into this kind of umbrella of COPD. Does that kind of make sense? You might have somebody that in the beginning stages of chronic bronchitis, well-maintained asthma, or maybe some emphysema. They might be kind of doing okay individually, but over time, they kind of all have the same, most of the same signs and symptoms, treatment symptoms. It's more just like an umbrella term if you have these restrictive lung diseases, it's chronic. So this kind of shows you this side is the normal lung. Okay, practice tip when we're assessing our patients. If this is our patient, we call this, which one is right or left? Is this our patient's right or left? Mm-hmm. That is their right, because if I'm the patient here, that is my right lung. A lot of students, especially when you're starting assessing people, get confused with that because they're like, well, no, I'm looking at this. This is my right. That's their left, right? So their patient's right lung here, this is normal. Here it has the alveoli, their airway. See how it's nice and open? The wall is thin. That's normal. With patients who have COPD, oftentimes the alveoli, they get kind of enlarged. And they can't expand and contract like they normally would with airflow. Also, there's increased mucus that can happen inside of you, depending on especially bronchitis, right? Remember about the acute bronchitis and a lot of mucus production. With chronic bronchitis, same thing, there's a lot of mucus irritation in the airways. And the airways themselves become thicker, constricting the airflow that can go through overall. So you can see how, wow, a lot of airflow can go through here, not so much through here. They really are obstructing what can go through, excuse me. So I have a lot of these pictures in the resource page. Sometimes they're helpful for students. So COPD, this kind of goes over what a patient might look like. What kind of position is he in? That's a tripod position, right? Especially adults. They like to lean over something. So sitting down or like leaning on the table, standing up, kind of doing this type of thing. That helps me think about like how the lungs are in our body. That kind of helps to open up the expansion of the lungs. Also looks like, hey, we got a guy with a cigarette and oxygen, that's real safe. So it could be from chronic bronchitis, right? That's one of the things that could cause or put somebody in the COPD umbrella. It's like the acute bronchitis, but it lasts longer. Typically, they're diagnosed once they've been ill for 3 months out of the year, or at least 2 consecutive years. So if you keep having this bronchitis, it's not just this acute thing that happens with the virus. It happens pretty routinely for several years. And they're like, okay, now you have chronic bronchitis. This is one of these little pictures. They like to call chronic bronchitis the blue layers. With the chronic bronchitis, because of all that mucus production, a lot of times these patients can even be a little bit cyanotic as their baseline. So they're not exchanging air like they need to. They have a lot of that plugging out the oxygen. With emphysema, somebody has COPD, that's where the alveoli lock, that's where the alveoli, they're getting expanded, they lose their elasticity, right? You guys have all seen a balloon, you blow it out, and once you let the balloon go, it's all floppy, right? That's kind of what the alveoli do. With that, you can actually, in that floppy area, it can't contract beyond the air valve, it's actually trapped there inside the alveoli. With that, sometimes we call these pink puffers. A lot more common to see. These patients have what's called a barrel chest because they're trapping air in their lungs. They can't fully exhale it. Their lung or their chest cavity actually changes shape. Their ribs will kind of see the air trapped inside, and so their chest cavity becomes more rounded and large to accommodate all that air that's trapped inside. With these guys, one thing to note, they do have that first lip breathing that we recommend. And that's where we're like, okay, instead of breathing it out, with your first lip. That helps to get some of that trapped air flowing. Normal exhalation, isn't as effective as that first lip breathing. A lot of times these guys will do it automatically, they can tell that it helps. You might also refer something from the time. So here, let's practice some first lip breathing. Here you can see how the air can get trapped in here, from the airway, getting kind of swollen, it's too elastic. Also from mucus, you could also have air trapping from the mucus itself, and won't let the air flow out. So in COPD overall, a lot of times the smoking, or even secondhand smoking like pollutants, those can all contribute to getting arthritis, asthma, emphysema, that can make you develop these respiratory issues. Overall, in COPD, these are kind of the common signs and symptoms: cough, sputum production, trouble breathing. That prolonged expiration, it takes them a longer time to get all that out because their alveoli just are a little bit floppy. With the chronic bronchitis specifically, that's when they usually have that really thick, tenacious sputum. It's like really sticky, really sticky. It doesn't want to come out. If they do cough it up, you're like, oh, that's really disgusting. They get those mucus plugs, and they have a lot of wheezing in practice. With emphysema, they have more diminished breath sounds. The air is just getting trapped in there. It's not moving as much. And they have a lot of dyspnea. So if we're monitoring a patient who has COPD, which of the following concerns us the most? Is it using accessory muscles, O2 side of 89, drowsiness, or a barrel-shaped chest?
Drowsiness. All right. I like that we had some interesting responses here. So let's talk about it.
So barrel-shaped chest, when we chose, we know that's a common sign of COPD. Oxygen side of 89. These people with COPD will often have a baseline lower oxygen saturation. And that's actually where we want to keep it on. Because of their decreased non-inflammatory issues, they tend to sat lower. And that's normal for them. They actually tend to become, sometimes the respiratory drive can actually come from the CO2 that builds up in their system. And so if we give them oxygen, their drive to breathe can actually go down because we're lowering their CO2. So I'm not going to get into all of that, just know, find out if the patient has COPD, what their parameters are. Because most of the COPD patients, they'll say, hey, you can put them on oxygen, but they only need to be at 90 or at 89, 88, whatever is normal for them. Use of accessory muscles, they might be doing that already because they have to kind of work harder. It's that drowsiness, right? Somebody who seems kind of sleepy, that's all you know, but it's actually affecting their nervous system and they're not getting the oxygen. Complications, poor pulmonal or just heart failure. You can develop heart failure from the issue of awareness. Weight loss, They can actually develop in your throats when your lungs becoming more thin and not stretchy. And eventually they can have respiratory failure. If we're caring for somebody with COPD, what following interventions should we implement? Let's select all of that.
All right, you guys did really well. So yes, always smoking cessation
And vaccination, good job. And coolness humidifier. That humidifier can help break up or give moisture to the secretions that are in the lungs and be able to let the patient have their avoiding help, we want them actually to use their inhalers. And their symptoms, they're not gonna be worse in warm weather. What time are symptoms usually worse for respiratory patients? Yeah, or cold weather. I went to the gym and worked out last night. When I walked outside in the cold air, it was like, and immediately it was like, I got that. Because it was starting to trigger an asthma attack with going from that warm working out environment to walking out into the cold weather. So the cold can trigger some of our respiratory issues. So therapeutic interventions, talked about all these supportive care, sometimes they need oxygen. The medications, bronchodilators, corticosteroids and expectorants. Let's talk about these corticosteroids for a minute, because I believe we have that on our medication sheet. So when we talk about corticosteroids, and I think some people got a little bit confused about this one on the homework assignment. A lot of times people are thinking, oh, well, it's like prednisone, right? With prednisone, especially if we think about a tablet, that goes systemically. We talked about this a little bit, I think, last week when we talked about Nasacort or one of the sinus nasal medications. Flonase is the other word for it, right? And that's, we want that to go localized for our sinuses, if we have allergies, sinusitis, and like that. Same thing with our patients who have lung disease, they might need some steroids to help with that inflammation. We don't necessarily want to give the corticosteroids because it goes through all our system, and then we're going to have systemic issues. So oftentimes we get them in food that has steroids. So your example titration is going to be fluticasone or Flodex or budesonide. Budesonide. BUDESONID. There's two really big nursing considerations with these medications. Right, why do we rinse our mouth? If it goes flush, right? So you gotta make sure if you use those, rinse it out, and I don't necessarily, I even try to spit it out because then you're swallowing it and it just goes really bad. But when people rinse their mouth after use. Anybody know another nursing indication? I'm so glad you brought that up. That would be the standard for the steroids. So if there's anything like they pill steroids, then we do want to take them off of the patient. We don't need to send them to. And we can have their blood sugars. Last fall or spring, whatever it was, that I had COVID and then just started to get loose for my they put me on oral steroids, and I was also on inhaled steroids as well. My husband was bad enough with the one day, they were like, you really need systemic corticosteroids. There's some side effects with those that it can cause blood sugar to increase. It can cause people to get really hungry because they come from the walls and all these issues that go with the corticosteroids. But I was looking out that I included them. Sometimes if they put patients on large doses too, they can them down because if you suddenly stop the steroids, you can have some rebound. The inhaled steroids don't have the same effect systemically, and they don't have the same rebound conditions. There is something that we do think about. So So think about. Yes, take the bronchodilator first. So last term I brought out like a little all my inhalers and I was like, which one do I take first? You take the bronchodilator and you open up your lungs, open up the airways, and then you take the inhaler steroid. That way, if it's steroid, usually you want to wait a few minutes because you want to let that bronchodilator work. It's just to decrease inflammation, anti-inflammation. Okay, I think that was all I had for those medicines. But those, guys, I'm telling you, these medicines, almost regardless of where you go work, you're probably going to be giving some of these or dealing with some of these. And those nursing considerations, and I'll post my one that has all like the answers on it for you. But like your pearls of wisdom, nebulized mistreatments. So like we talked about before, you can use a Resp inhaler, which is like a MDI or meter dose inhaler. That's just a little one. Or you can have a nebulized treatment, and that's where it's in a liquid, usually in saline or sterile water, and it's like you're breathing up in the mist. One thing with kids, especially, you want to make sure that they know how to use their inhaler. A lot of kids have a hard time like coordinating breathing in as activating the device. So a lot of times we have spacers that we use. And I should have grabbed something to that. But essentially, it's like a little tube, and you spray the medication into the tube, and then they just breathe from the whole. So actually, things are a lot about. I have a friend who's a doctor in Africa, and he uses these as spacers for his kids there because they don't have a lot of medical care that's readily available. And so if you cut a hole here, then you insert your inhaler like this, then you can deploy it, let it from here, and then you tell the kid to, obviously it's going to pack their water to breathe in the medication. So that's a way that a lot of times we teach kids how to use the fingers, because if they're not coordinated enough, all that medicine is going to hit the back to the right? And even adults too. Sometimes we struggle coordinating the breathing, so this feature can really help. Let's see, question for you. If you have a 79-year-old female who reports chronic productive cough for the last 3 months, she tells you, this is just my winter cough. What do you think she looks like for bronchitis? Septicemia, chronic bronchitis, emphysema.
This one was too easy. You're right, chronic bronchitis.
Right? She's coughing up all of that stuff. 3 months. She told that she has it quite often. So asthma, we've been talking about it, a little bit now and then, but very similar. You can have inflammation. You have spasm that happens as well. So sometimes it's not just that there is like trapped from swelling inflammation. You can also have those bronchial spasm, which can cause the air trapped inside. It's usually reversible. That's one of the things that with asthma is different from emphysema and bronchitis, is that if you have an ear asthma flare up, usually you can treat it. Over time, though, you can have some airway remodeling, meaning airways that get kind of enlarged and squishy. Not saying I'm not pretty good about something. It can be hereditary. It can be from allergies, pollutions, smoking. Those can all be things that can trigger somebody to develop asthma. The triggers itself, or I said, etiology, what can cause them to develop asthma. The triggers as far as what causes the asthma to flare up issues can be anything from smoking, allergens. If you have sinusitis, you just have inflammation in your sinuses or anywhere in the airway tract, that can cause an asthma attack. Stress, right? Some people go in to take a test and all of a sudden their asthma flares up. That's stress. All those chemicals our bodies make put them into an asthma attack. One thing I don't know if I see, allergens. I didn't really talk about that, but talk about pets, dust, or different things. Like I know I had a doctor one time who was like, you really shouldn't vacuum. Because when your vacuum is like all like exposed to all the dust, I was like, who's gonna vacuum? Like what do I had babies like you, I had them back to back, and I was like, if I don't vacuum, I don't think anything is gonna get done, so like, we're in this. But, you know, we can encourage people, like, maybe you don't have carpet, right? If you have wooden floors, it's easier to sweep up. Curtains, especially heavy curtains, those can carry a lot of dust and things, so trying to, work their environment to be a little bit more healthy for those patients with asthma can help, especially if there's kids, right? Because kids, I mean, it's everywhere, around everything. So signs and symptoms, usually it's that trouble breathing, dyspnea, wheezing. Wheezing is one of the hallmark sounds you're gonna hear with asthma, so constricted airways. Cough, sputum, and oftentimes it can be used worse at nighttime. Do I have a picture? Okay, not yet. The LPN is assessing a patient who begins to exhibit manifestation of an asthma attack, which concerns us the most. Dyspnea, wheezing, nothing of good for sputum, reducing accessory muscles to breathe.
Look how good you guys are using accessory muscles, right? That tells us that we're really struggling to get our air. This video is of a kid who's having an asthma attack. They're actually getting ready to intubate him. Look at his accessory muscles. I think it's a boy, it might be a girl. When we say accessory muscles, you're looking intercostals in between the ribs. They're going to be retracting the whole air in. He's going to be using his diaphragm to really push and pull air, as well as the shoulders up here. You can see some retracting as he's like pulling up here. Let me start it.
Shows a child with obvious respiratory distress who is about to be mechanically ventilated. The respiratory therapist is getting ready, along with the physician, to intubate this patient and place a plastic tube into his trachea and breathe for him. Notice the anatomical accessory muscles of respiration. You can see the diaphragmatic excursion, the anterior scalenes, sternocleidomastoid muscle. You can also see the internal and external thoracic muscles. This video reinforces the importance of the anatomy of the chest cavity.
Okay, that one, I don't love that video because it's kind of hard to see a kid struggling to breathe like that. But it really, I think it shows so well those accessory muscles. On adults, it can be harder to see those because usually you might be a little bit larger, and then we have breasts that develop over time, and so it's harder to see. So know that you might, in adults, accessory muscles up in here, sometimes on the sides, back over here is where you can better see intercostal retractions. But if you're working in pediatrics, that's what you're gonna see if you have a kid who's really struggling. If you're seeing that, that's a big red flag that says, I need help, okay? My biggest thing with my students, if you're ever nervous in the clinical environment, it's okay, just don't be nervous alone. If I saw this kid, I would be nervous. I would be gathering a crew around to help me. So tripoding, like I was saying, this would be adults and they're sitting or standing. Kids are a little bit different. So if you're assessing a kid, sometimes they tripod backwards, right? Because if you think about adults, especially women, we have more tissue and things. So we usually lean forward to help pull our chest open. The weight helps to open our chest. Kids don't have that. They're usually pretty thin. So they tripod back. And that's what helps them to open up their breathing a little bit more. So you see a kid doing this, and he's looking like he's struggling to breathe, that lets me know that he's actively working hard his lungs. So status asthmaticus is a complication of asthma, and that's when you have a severe sustained asthma issue. That video we saw, like could probably be called status asthmaticus. There's something going on, and that needs emergency immediate treatment. Usually, we're going to give nebulized treatments. We're going to give them some kind of IV steroids, the corticosteroids. We would give the IV, why would we give an IV rather than oral? It works. moves faster. And then they might need mechanical ventilation if you can't do it with the flow. So peak flow meters, you might have a test question about it. Generally, we don't use them anymore. Sometimes in kids, they like use peak flow meters. That just tells you how well you're breathing, how much you can breathe in them out. So with kids, we don't do it. With adults, usually just say, hey, how often are you breathing your rest? That's how we kind of see how well their symptoms are managed. Because for adults, like, well, pretty much every day or twice a day. That's probably not managed super well. Probably we might want to kind of do something else to manage their baseline symptoms. Bronchodilators. So leukotriene inhibitors. That's one more I don't think we covered yet. So leukotriene inhibitors, that's to help with allergic response. And we give that a lot to patients with general seasonal allergies, but also our asthmatics really can help with that. So the action, it just blocks the effect of leukotrienes, and that's like white blood cell, that's the inflammatory response. Example medication would be Singulair. Nursing interventions, you want to monitor patients with behavioral health issues. Sometimes it can alter the mood or mental stability of patients. But if you have a patient with asthma and they're triggered by allergy, your medicines are really good at having control of their symptoms. So if we're caring for a patient who's taking fluticasone, what of the following is the most important for the nurse to implement? We monitor the blood pressure for high doses, instruct to rinse them out after, use steroid before bronchodilator, or instruct the overuse of every 100 hours. I think it really should have been a select all that apply, because we want them to use, we want to rinse them out. Oh, never mind, it's not right. It's right. I was thinking use bronchodilator before steroid. I flipped it in my mind. So if you chose this one, bronchodilator first, open up the airway, then the other medicines like steroids can get them to go. All right, cystic fibrosis. This is a disorder that's hereditary. It's characterized by these thick secretions in the lungs. And we talked about with chronic bronchitis, they have these thick secretions. These guys, I mean, it is like they're so thick and it's copious, so much that they have. There's also, because of the immune disorder, there's some pancreatic enzymes that they don't produce, they just not able to. It's a hereditary condition. We usually see it in kids, oftentimes because they die before they're able to go. They have this thick sputum, they have frequent respiratory infections because in all that sputum or the blockage, they might even, as teenagers, start having COVID because they've already had this. They have this fatty, foul-smelling stools, and they don't absorb their food very well. That's part of the pancreatic. Not the pancreatic. Your pancreas produces enzymes to digest food. And if they're not producing them, they're going to have some digestive issues. And then oftentimes they can develop some resistant infections, the bronchs, and pass away from them. You know, there's genetic testing. If you have this in your family, they might just want to know. There's this Kiss Your Baby campaign because of the way that it works. It's a way that they excrete sodium. And so oftentimes, like their skin, if you kiss them, like your lips might taste salty. So if you kiss your baby and your lips taste salty, it's a good material check for cystic fibrosis. I don't hear that anymore. That's kind of an old one, but it kind of helps you remember the kiss your baby. You have this kind of a story with how you absorb things too. So therapeutic interventions, right? We're just trying to control the disease. So think about the secretions that you can have hydrated so they can pass them out. We might give them um, medications to help out all those secretions. Bronchodilators, corticosteroids, expectorants. You guys know what CPT stands for? It's, percussion therapy, continuous percussion therapy or something. Like that? Compression physical therapy, yeah. So the flutter valve is trying to limit that by kind of giving you some, like, to break up secretions as you breathe. Externally, just gonna do my practice on you. Yeah, so when you have respiratory therapy, that you can tell a little bit, usually they cut their hand, like. You go all along the lung, it's usually you actually start at the bottom, because right, you wanna start breaking it up to then pop it out. And so they do it for a while, to try to break up all those secretions. Actually, a lot of our beds now, the beds, they have some to, like things you can put them into. So just like a massage, maybe that you'll see the bed like shaking the people, but it's like trying to help break out all of those secretions. Oh gosh. We try to help them prevent infection. In fact, these guys, if they're starting to get a little bit sick, they'll dip them out in antibiotics, which is the average kid, because we know that we are so much more at risk of getting a secondary bacterial infection, and that infection can really cause a lot of problems. Oh wait, throwback. Which of these is a restrictive disorder? So remember, infective, restrictive, occlusive, emphysema, chronic bronchitis, asthma, or colitis. Good job, you guys. Restrictive, right? The chloritis, it kind of is putting pressure on the lung. Okay, that's it. Before we go, I just want to do a quick game of name that patient, and we will be done. Yes. Oh, let's go over it. So the question was individual, and thank you for bringing it up, because that was my little note of the reminders or whatever I said on there. So in week 8, you guys have this individual project compare and contrast endocrine disorders. There's also this compare and contrast worksheet that's associated with it. So this is the discussion board. So there's a lot of different endocrine disorders. What you're going to do is fill out this sheet that talks about all these, and there's 12 different endocrine disorders. And all you have to do on the sheet is say what are the signs and symptoms, and what are some therapeutic measures, how you treat it, right? Here's some intervention. You fill that out and you submit that sheet to that other assignment that says the compare and contrast worksheet. This assignment is the discussion board where you have been assigned a certain disorder, one of these. So what you will do is say, hey, for whatever your assigned dysfunction, say, how is it different than normal function? Name 3 ways that this disorder will impact their lives. Plan 3 nursing care activities for patients with these changes. And then identify at least 1 safety measure that promotes safety with your assigned condition. You can see which group you're in, or which, I think, can you guys do people? I'm trying to remember. If you go to people, there's MS2 endocrine project. And then you just have to open them up to see who you are. So I'll just open these up so you can see. You know what? We're not gonna have time for our name that patient. So let's do it next week. So next week, before we start anything, you guys will be name one of these people. Have a great rest of your week. If you need to see which group you're in or which disorder you have, let me know. I'll scroll to it. If you go to people, let's see. Here you are, Cushing syndrome. Right, I need to go through my test analysis, so based on that, you may get more. For now, it's what it is, I still have to do the test analysis. The one that's due next week, it's just an assignment, you take it at home. I ask you take it, you don't use your book, you don't use your resources, it's not fair, you get full points just for taking it. The one that we're doing on the.
The one that's.
Yeah, then that's the one that you're actually, like, as.
If you're gonna get. You know, the other one. Like a 65.
Right, right.
So it is.
Yeah.
I'll bring the picture.
Also is the science, yeah, it's not graded as a small, it's graded as a.
So it would like have a little.
It won't wait, yeah, it won't grade it that much. Yeah. Oh, I can show you, so hold on, let me stop the recording. You okay, Caroline?